TB still remains a major public health issue driven by the large number of people with TB that are not diagnosed or undetected. So just to be clear, if you look at the global figures, there's about approximately 10 million people that are estimated to have TB globally, but only about 7.5 million or maybe 8 million people are diagnosed and treated, meaning that there's about 2 to 2.5 million people globally every year that remain undiagnosed and undetected. In South Africa, it's fairly similar. There's a lot of undiagnosed and undetected TB. But when we look at, it's even worse when we look at the actual data from prevalence surveys, which actually go into communities rather than just looking at routine data, but actually go into communities and use a systematic approach to test people for TB and measure that prevalence. And on that basis, the gap could be as high as 50%. So there's a lot of people with sort of early TB that we also don't get. And I think that's probably the major issue. The biggest barrier, I would say, in controlling TB in South Africa is, to a large degree, education and stigma. So often people see TB when it's very advanced, when people need to be hospitalized, but that often is very late. So I think the underlying issue is for people to understand that when they do have symptoms like a cough, especially in the South African context, and they have some risk factors, it's important that they get tested for TB. So that's the first, I'd say, important message. The second, I think, is also the fear that people have of a TB diagnosis. So there's been a lot of stigma historically related to TB, especially TB in South Africa, with the high mortality and its association with HIV. But I think that stigma has still sort of carried forward over a decade, and we don't really see what we see like 10 years ago. A lot of people are cured. We have exceptionally good success rates for susceptible and drug-resistant TB. So I think there are barriers, but times have changed, and I think it's about changing the mindset and creating better education and sort of being clear on the current status of TB rather than people being stigmatized. TB is really complex in South Africa by two major factors. The first one relates to HIV. So we know that HIV has quite a negative effect on a person's immune system. Once the immune system or sort of the soldiers of the body start being depleted, then TB activates or reactivates, and makes a person more susceptible to a TB infection. So TB has been a major driver of, HIV has been a major driver of TB in South Africa from the 90s and led to an explosion of TB in South Africa because of that reason. However, I'd say in the past decade, or at least minimum 5 years, we've seen major strides in success of controlling HIV. Lots of people are aware of their status, lots of people are on ARTs. It's become normalized, and that has led to a massive reduction in the amount of TB we have. So that's the one driver of TB in South Africa. And if you look at the prevalence survey in South Africa, they actually found that there's more HIV negative, so people who are HIV negative, who don't have HIV, that have TB than there are those with HIV that have TB. So this whole idea of HIV-associated stigma is becoming a misnomer going forward. The second issue around poverty. So yes, TB historically, and even before the HIV epidemic had started, TB had ravaged Europe for decades, or if not a century. And the thing that reduced the burden of TB was all not because of antibiotics or vaccines. It was really around socioeconomic improvement. And there was an interesting study. So that malnutrition is a big problem with driving TB globally. in South Africa as well. But I think like countries outside of sub-Saharan Africa, it is even more prominent. So for example, in India, there's a fascinating study that showed that by giving food hampers to people with TB, they reduced TB mortality and they reduced overall incidence of TB. In the past 5 years or so, we've seen a revolution on the diagnostic front. So it's not just expert. We have, I think, about 7 or 8 different manufacturers that are producing TB tests. Just about a week ago, or maybe 2 weeks ago, the WHO announced its first recommendations on what's called a near point of care test for TB. So large, and I was quite involved at WHO before I came to Edwards dealing with that issue. And most of our TB tests have largely been lab-based. So often you need to send the samples, wait for it to come back, and then initiate treatment. And this near point of care technology now opens the potential for providing diagnostics for TB at health facilities. So you could leave within 30 minutes with an answer. So I think that's one major revolution in diagnostics. In terms of drug-resistant detection, South Africa had implemented sequencing as a primary test for detecting further resistance after the rifampicin resistance is detected. But on the treatment front, it's been really good. I think on drug-susceptible TB, we have fantastic treatments. The treatment for drug-susceptible TB is still exceptionally good. But what has been two revolutions, I think the efforts towards trying to shorten the regimen, while it hasn't really panned out to be as successful, but for children, for example, using the standard therapies for 4 months in non-severe TB has proven to work. So that's already shortened it for children, and it's quite difficult to treat children with TB, especially the types of medications. But I think the major revolution in the treatment space has been for drug-resistant TB. When I started my initial work with TB, success rates for MDR TB were like 50%, meaning other 50% were unsuccessful or died. For XDR TB, it was even worse. Treatment was for 24 months. It required injections. People were developing deafness because of the treatment. And now we have this new, what's called the BPEL regimen. It's a 6 months all oral treatment, and the success rates are like 80 to 90%. So a massive revolution. So, already on the diagnostic and treatment front, we've seen major gains. And what's amazing, when I started my work in TB, TB vaccines were like a dream. And South Africa has been a leader now where we actually trialing the first ever at scale, trialing a TB vaccine. So I'm very hopeful for the future. So on the research and development front, there's quite a lot happening. The two things I'd like to really highlight in this work that I've been leading on and led on. So the first was, from what I've spoken, right, we've had lots of biomedical interventions, all the treatment stuff, all the diagnostic stuff, really making, dealing with the biomedical issues. But we still see a lot of people that might come for investigations and then do not come back for the results, never get started on treatment, or if they do start on treatment, never finish the treatment. So success rates have been, even with all our efforts to try and get people into care, we've been unsuccessful in getting them to cure. And we know there's two factors. Our health system is not very good at speaking to people. Speaking to people, counseling people is not something, like HIV does it, but TB has not really done it strongly. And the second is, we know that most of the people that develop TB from the poor socioeconomic status. So often they might not have, a lot of people don't even have jobs, right? So to pay a taxi fare to come and to go, that alone is a tough thing for them as well. So what we had done we did what we called a conditional cash transfer and counseling and conditional cash transfer study. So we randomized people to standard of care, or we counseled them pre and post the test, and we gave them 150 Rand for them when they came back for the result and started treatment. And it's a 6 months treatment, so every month they came, we gave them 150 Rand. We did it through digital electronic transfers. And that actually reduced the unsuccessful outcomes by half. So that was a paper published in Lancet about not too long ago, and really showed a significant reduction in unsuccessful outcomes by just providing basic counseling and providing some financial support through that treatment. So that was, I think, a really important study, and that will take some traction in public policy going forward. The second one, I mentioned that this new test for TB is now recommended by WHO. So these tests, we've just managed to get some funding from Gates Foundation to do evaluation within the laboratory services. While the performance on the global data seems to look really good, the South African context is a bit different in a sense that we do have a much more aggressive program to try and identify people with TB with the TUT and TUT Plus type of projects. So the technologies for diagnostics don't work as well as they would in other settings, because we're often trying to get people at an earlier stage of disease. And so the technology has arrived in country. We'll be kicking off a study in April, where we'll be having 2 of our sites here at Wits University, and still discussions with some of the other sites across the country, about a total of 6 sites, and we'll test about 7,000 people, comparing the sample that's submitted routinely for the routine care test versus this new test, and really sort of do a head-to-head comparison to understand its performance in our setting and how well it works for people that are in hospital setting versus clinics. And that will really provide us the first indications of this new technology and its accuracy and performance. And the expectation is that we'll do this fairly rapidly, and then that information could be used by the bigger demonstration projects that have been planned by the Department of Health and NHLS and other key stakeholders in deployment of the new technology. I think those are the 2 key things. I mean, there's been a lot of researchers developing vaccines and other things. Prof. Bhavesh Kane has done some work on trying to innovate a new TB vaccine, which is fantastic. There's a variety of other researchers at Wits that are doing a lot of work on case finding strategies around this new technology. How well will it work in primary healthcare settings? Could it be used in casualties? So I think there's a lot of innovative and R&D work happening at Wits.